Ladies and gentlemen, please welcome Dr. Timothy Buckman, Editor-in-Chief of Critical Care Medicine, Dr. Robert Tasker, Editor-in-Chief of Pediatric Critical Care Medicine, Dr. Darren Teichman, Deputy Editor of the New England Journal of Medicine, and Dr. Christopher Seymour, Associate Editor of the Journal of the American Medical Association.
Hello, SCCM. I'm Tim Buckman, and it's my pleasure to welcome you to this late-breaking plenary session. This afternoon, authors and editors are coming together to share their studies, our studies, each carrying the imprimatur of the journals. These reports have been shaped by cycles of peer review, presented in formats old and new, and are presented here today to help you deliver the best care to your patients. Here's what's exciting and impactful. And while the world is going to gain simultaneous access to the print and electronic versions, you have the privilege of hearing how the author posed the question, performed the work, and interpreted the findings. And at the conclusion of all of the presentations, you'll have the special privilege of asking questions here at the many microphones. Well, here to start this late-breaking plenary session today and to introduce a late-breaking article from the New England Journal of Medicine is Dr. Darren Teichman.
Thank you, Tim. The first study today, which compares restrictive and liberal fluid management for sepsis-induced hypotension, the CLOVER study from the Parental network, will be presented by Drs. Ivor Douglas and Nathan Shapiro. Ivor Douglas is a professor of medicine at the University of Colorado and chief of pulmonary and critical medicine at Denver Health Medical Center, where he has directed the medical ICU since 2002. He's the principal investigator for ongoing investigations in several aspects of critical care, including basic mechanistic and translational studies in acute lung injury, sepsis, and shock resuscitation practices. Nate Shapiro is a professor of emergency medicine at Harvard Medical School and an attending physician in the emergency department at Beth Israel Deaconess Medical Center. Dr. Shapiro is a translational and clinical researcher who focuses on the diagnosis, prognosis, and treatment of patients with sepsis. His research includes endothelial pathobiology, as well as an assessment of fluid resuscitation practices. I'm so happy that we will be simultaneously releasing this paper on the New England Journal of Medicine website. Thank you.
Good afternoon, SCCM. My thanks to Dr. Teichman. Appreciation to SCCM for hosting the presentation of this publication, and welcome and introduction to my colleague, Nate Shapiro. We're going to divide this presentation into two parts. We're going to present the background and motivation for conducting the crystalloid liberal or vasopressors early resuscitation study in sepsis, which I'll refer to as CLOVERS, on behalf of the National Heart, Lung and Blood Institute's Prevention and Early Treatment of Acute Lung Injury and Network. It's really an honor to represent a cast of thousands. This particular investigation is the work over 7 years of a large number of investigators and coordinators at many sites, 60, many of whom are in the room and with whom we share the opportunity to share our work. The primary question that we had sought to address in CLOVERS was which of a broad spectrum of therapeutic approaches for optimal fluid resuscitation in septic shock affords the best outcome when we look at survival. On the one hand, one end of the spectrum of care is encapsulated in an approach which is a more restrictive approach when it comes to fluids and prioritizes early vasopressors with a priority to prevent progression of both interstitial and macroscopic edema. And there are many studies that associate accumulation of fluid with high fluid balance with higher mortality. The other end of the spectrum of usual care focuses on a more liberal approach, fluid loading to augment preload, optimize organ perfusion, improve microcirculatory dysfunction, and in large part represents empiric usual care across the world. Now, this question has been addressed at several levels, both in ICU cohorts and emergency room resuscitator patients. And this meta-analysis, looking with the point estimate representing the size of the cohort, in aggregate would suggest a small small attributable benefit to strategies that focus on a more restrictive approach. The largest study of which, by Mayhoff and others, the classic study, was focused on only ICU patients. So we hypothesized in CLOVERS that a restrictive approach, vasopressors followed by fluids, compared with a liberal approach, fluids followed by restrictive vasopressors, would result in an improvement in 90-day mortality before discharge in patients identified very early on with sepsis-induced hypotension. CLOVERS was a multicenter, prospective phase 3 randomized controlled trial. It was non-blinded for reasons related to the protocol, and the intervention period was 24 hours of both fluid and vasopressor titration. The study, which was powered around change in 90-day mortality, sought to detect a 4.5% absolute difference in a previously estimated 15% prevalent mortality rate. And we planned the study with 2 interim analyses and a final analysis to look at both efficacy and futility. The study was conducted across the 60 hospitals that participated in our CLOVERS Parental network, with Mass General Hospital as our clinical coordinating center. And at the onset, we designed the study to really capture the spectrum of usual care presentations of sepsis in adults with a suspected or confirmed infection who had persistent hypotension, which we operationalized as a blood pressure systolic less than 100 or mean arterial pressure than 65 after at least a 1-liter fluid challenge, but no more than 3 liters of crystalloid fluid. And the exclusions thus included a long delay between meeting inclusion criteria, 4 hours, or since primary admission, persistent hypertension from a non-sepsis cause, or extreme hypovolemia, such as happens in diabetic ketoacidosis. In addition to our primary outcome, we identified several important organ failure, process, and systems outcomes as secondary analyses. Our protocol was designed with an intention both to separate the 2 arms between the fluid restrictive group, where once a patient was randomized, all usual care fluid was discontinued. Pressors were then titrated to maintain hemodynamics. And there was an opportunity to capture usual care decisions around rescue fluids, which could be administered by the clinical team either for indication or at their discretion. Similarly, in our liberal protocol, up to 2,000 mils of crystalloid fluid could be given in 1,000 ml boluses with an opportunity to forego the second 1 liter of loading if there was a clinical reason to do so. The protocol similarly used fluids to achieve target blood pressure, and there were opportunities to use rescue vasopressors with monitoring not pre-specified but being used according to the usual care practices in a way that allows for personalization of the care at the bedside by the investigator. It's my pleasure now to invite my colleague, Nate Shapiro, to present the findings.
Thanks much. So after the study, the trial was stopped for futility without evidence of harm at a planned second interim analysis. At that point, we had enrolled 1,563 patients over just a little under 4 years. Here's the consort diagram where we screened roughly 12,000 patients. Approximately 5,000 were eligible, 1,563 randomized, of which 782 went to restrictive and 781 to liberal. As you'll see here, the reasons patients were eligible and not randomized tended mostly to be around the ability to get informed consent from a patient or surrogate or locate a surrogate, as well as for clinicians entering their patient into the trial. The patients enrolled in the study were quite representative of the types of patients that present with sepsis to our hospitals. Approximately an age of roughly 60 years old, 70.7% white, 15.8% black, and 14.5% identified as Hispanic. When we look, this highlights some of the comorbidities we saw in the trial. There was a good distribution of equality between the 2 groups. About 28% were diabetics, 11.5% chronic heart failure, 4.7% end-stage renal disease. Here we highlight that patients were enrolled quickly. 61 minutes passed typically On average, that's the median time from meeting criteria to randomization. 92% of the patients were in the emergency department at the time of randomization, and the median amount of fluids was strikingly similar between the two groups at 2,050 cc's. So this slide now shows us, or asks the question, did we perform a clinical trial? Did we have a group of patients who had a restrictive approach and compare them to a group of patients who had a fluid liberal approach? And I would submit that these data support that we did in fact have a clinical trial. If we look, a lot of the separation occurred over the first 6 hours, where we see 2,300 cc's in the liberal group compared to 500 cc's in the restrictive group, for a difference of 1,800 cc's more fluid in the liberal group. That persisted out to 2,134 cc's difference in the 24-hour period that the protocol occurred. When we look at the other side with use of vasopressors, 59% of patients in the restrictive group received vasopressors as compared to 37% in the liberal, for a 21.7% difference. The time from randomization to first vasopressor was shorter in the restrictive group, and the duration of vasopressor use was longer also in the restrictive group. So taking another look at this, just because I think this is an important part to understand and interpret the trial, again, pre-randomization, the fluids were the same, and then we have about a 2-liter separation that occurs over 6 hours, that persisted, or there's a little more separation over 24 hours, and when you incorporate pre-randomization fluid up until 24 hours after randomization, you see it's 5,400 cc's compared to 3,300. On the other side, the restrictive group received vasopressors more often, earlier, and longer. So at the end of the day, in setting up our hypothesis of a fluid-centric group, we saw that in the liberal, where there was more fluids with less and later vasopressors, compared to a restrictive group, which was vasopressor-centric. The primary outcome, 14% mortality for death before discharge home by day 90 in the restrictive group, compared to 14.9% in the liberal group, difference of 0.9%, p-value of 0.61. No difference between the groups. When we look at the Kaplan-Meier, we'll see these lines are strikingly close. So at the end of the day, there was no difference. When we look at secondary outcomes, organ support-free days, ventilator-free days, hospital-free days, I'm showing a couple of them here. The rest are obviously in the paper, but no difference. Other secondary outcomes, renal function, organ function, ARDS onset, no difference. New intubation and serious adverse events, also no difference in these important safety outcomes. There was a number of pre-specified subgroups that we had identified for analysis, and the summary is no difference across any pre-specified subgroup. I'll highlight 2 of them. One is chronic heart failure, where the point estimate was strikingly close to 0, and end-stage renal disease, where the point estimate was further away, but the confidence interval still crossed 0 in the 73 patients in this trial. I'd also like to share some other metrics, or we'd like to share some other metrics, which was ICU utilization. This is a post hoc analysis, but we felt it warranted presentation, which is 8% more patients in the restrictive group ended up in the ICU during the protocol period, and that was sustained over the first 7 days. There was also higher central venous catheter insertion in the restrictive group. Another part of our trial, and while this wasn't part of the randomization process, we identified in the trial that the use of vasopressors was becoming more common. Vasopressors administered through peripheral catheters was becoming more common in clinical practice. So we actually incorporated this as a protocol allowable action in the trial, and we included it in the consent process. So in total, 500 patients in our trial received vasopressor infusion through a peripheral catheter. There were 3 identified complications, of which all 3 events resolved without intervention and did not have any clinical consequences. So 0.6% event rate, and the events were self-limited and had no clinical confidence. Perhaps this data is in support of this practice. So a couple items, there's a lot to unpack in this trial. A couple things to unpack as people interpret it. I'll mention a few. First is the results applied to the type of patients enrolled in the trial. Patients identified early, patients who are not at the extreme of volume status. In other words, if you're volume overloaded, you weren't in the trial, and if you're severely volume deplete, you wouldn't have been in the trial. And our patients received about 2 liters on average median fluid before entering the trial. I'd also like to call out, as Dr. Douglas highlighted, that there was a degree of personalized care in the trial because we all felt this was important as we designed the protocol to incorporate in such a protocol. So there was enough flexibility that you had a vasopressor-centric approach or a fluid-centric approach, but you weren't locked in to only use one modality or the other. Use of hemodynamic monitoring was allowed, but it wasn't commonly used, and it wasn't really part of the protocol or part of what was studied. It's possible there's a future direction for hemodynamic monitoring that wasn't addressed here. In our study design, we had a hypothesis of fluid liberal versus fluid restrictive, which was vasopressors early and less fluids. 2 arms in the trial, and that's what we tested. We considered but decided not to include an unstructured or wild-type arm as we thought that there'd be issues with generalizability, and so this is what we postulated was the best design for our trial to answer our hypothesis, and that's why we went with that design choice. It's also possible there's subgroups out there that we didn't test. Maybe there's endotypes. Endotypes identified through more advanced analytic techniques, which may or may not include advanced microbiology testing or advanced protein assay testing or RNA testing, et cetera. There could be subgroups out there who may benefit from one strategy or the other, but we did not identify them in this trial. And so putting it together, maybe future efforts need to look in other areas in order to improve mortality and sepsis beyond how to manipulate vasopressors and fluids. So in conclusion, the fluid restrictive strategy, as compared to the fluid liberal strategy used in this trial, did not result in lower or higher mortality prior to discharge home before day 90 among patients with sepsis-induced hypotension. We performed a trial where we had 2 strategies, fluid liberal, fluid restrictive. The data show that we were able to effectuate those strategies, and at the end of the day, both seemed to address hypotension, and neither led to a higher or lower mortality. It was the same. Thank you very much.
Thank you, doctors, for an outstanding presentation. I'm now pleased to introduce Somnath Bose. Dr. Somnath Bose is an assistant professor of anesthesiology at Harvard Medical School and a practicing intensivist and researcher at the Beth Israel Deaconess Medical Center in Boston. He serves as the medical director of the ICU at Beth Israel Deaconess, Needham, and co-director of the Center for Humanizing the ICU at the Beth Israel Deaconess Medical Center. He's federally funded and invested in outcomes research with a specific focus on improving the quality of survivorship following critical illness. The article he will be presenting, titled Association Between Unmet Non-Medication Needs After Hospital Discharge and Readmission or Death Among Acute Respiratory Failure Survivors, a Multicenter Prospective Cohort Study, will be simultaneously released in the official SCCM journal, Critical Care Medicine.
Good afternoon, everybody. Thank you, Dr. Buckman, for that introduction. And it is a pleasure to present our work in front of this audience. And thank you to the Congress Programming Committee for giving us this opportunity. I'm going to be presenting our work on behalf of the APEX-1 study team. So our work was funded by the US Department of Defense, and by means of disclosure, this is the opinions that we're going to be expressing are solely those of ours and not necessarily endorsed by the US Department of Defense. I do not have any relevant disclosures. So jumping on to the topic of survivorship, we are all aware that as care has improved, survivorship following respiratory failure has increased. What this means is that we have larger amounts of survivors of critical care who experience new or worsened health states across multiple domains. And this has been increasingly recognized as PICS. And post-intensive care syndrome is a urgent research priority, and there are a lot of efforts being done to mitigate the burden of post-intensive care syndrome. Now, we all know that as patients move from one phase of recovery to another, their needs evolve. And for the purposes of this presentation, we are going to be focusing on this early post-discharge recovery period, which is somewhat understudied as of now. So if we look into the post-discharge needs, these can be broadly categorized into two. We could classify them as medication needs and non-medication needs. Now, if you think about the needs, non-medication needs could be used as an umbrella term for durable medical equipment, home health services, and follow-up appointments. So we know from from literature that there are major gaps in care as following recovery from critical illness. But what we do not know is whether there is an association between early non-medication needs and subsequent outcomes. Now, we have in the past presented the complex relationship that exists between unmet medication needs and outcomes. So for the purposes of this study, we are going to be focusing on the unmet non-medication needs. So we had three broad aims for the study. One was to characterize the proportion of non-medication needs that go unmet, analyze the association between such unmet non-medication needs and a composite outcome of readmission or death within 3 months of discharge, and as an exploratory analysis, try to identify predictors of unmet discharge needs. So ours was a prospective multicenter cohort study, which was conducted across 6 academic medical centers across the breadth of the United States. Here's the inclusion criteria. For patients to be included in this cohort, they had to meet these two inclusion criteria. They had to be adults with acute respiratory failure, and for the purposes of the study, acute respiratory failure was defined as the need for more than 24 consecutive hours of mechanical ventilation via an endotracheal tube, or non-invasive ventilation or high-flow nasal cannula. And they had to be, after their ICU stay, be discharged home. Looking into the major exclusion criteria, respiratory support solely for airway protection was an exclusion criteria. Advanced dementia, according to IQ code screening, was an exclusion criteria, and inability to complete telephone-based follow-up excluded patients as well. Here is a schematic of our study. So the exposure for the study was a proportion of unmet non-medication needs, which could either be durable medical equipment, home health services, and follow-up appointments. The exposure was ascertained within 7 to 28 days of discharge home, and this was done through a centralized data coordination center, which was housed at Johns Hopkins Medical Center. And this was done with the help of a questionnaire which was designed solely for this purpose with the help of multidisciplinary input. The outcome of interest was a composite of readmission or death within 90 days of hospital discharge, and we also looked at the components of the primary outcome. Here's a brief overview of the statistical analysis. The exposure unmet non-medication discharge needs were dichotomized as above or below median, and we expected in our cohort to have reverse causation and confounding by indication. So a propensity score adjustment was used to estimate the average effect. And for the primary analysis, a Poisson regression was used with the propensity score as a covariate. Exploratory analysis was conducted using a random forest model. And for all analysis, a two-tailed significance threshold of 0.05 was considered significant. So coming to the sample size, we did some simulation before embarking on this trial, and we came to the conclusion that we would need about 152 patients to detect a difference of about 23% difference between patients who had unmet needs or higher unmet needs categories versus those in the lower category. And we built in an attrition rate of around 24% and enrolled 200 patients. So we've gone through some of these before, but the study was overseen by the Central IRB at Vanderbilt, and we obtained informed consent prior to enrollment. So here is the CONSOR diagram. So over a period of about 20 months, we screened about 5,700 patients. Eventually, 200 patients were enrolled, and 195 patients were included in the analytic cohort. To give you an idea of what our cohort looked like, the median age was around 55 years, with about 53% females. The population was mostly insured, so this is something to bear in mind, with only about 5.6% patients who were uninsured. And we had about 16.9% patients with COVID in this cohort, because this literally finished as COVID was ramping up. Aftercare, and only about a sixth of patients were enrolled in any form of ICU recovery program. So this is a snapshot of how the non-medication discharge needs that were identified. So almost everybody, or about 98% patients, had about at least one identified non-medication needs. Of these, follow-up appointments were the commonest, with about 97% patients having an identified follow-up appointment, and about 70% needing home health services. And if you looked at the intersection of all these, about 48% patients had a need identified in at least each of the three categories, and about 31.3% had needs in two categories. This schematic shows the needs and the proportion that were unfulfilled. So if you look at absolute numbers, follow-up appointments were the highest at about 600, and about 37% of home health services remained unfulfilled. So this is giving a snapshot of the proportion of needs which went unmet. So looking at all comers, patients had a median of 5 needs with an interquartile range of 4 to 8. But what I would like you to focus is the number on the extreme right, which shows that about 2/5, or 44% of patients, had at least one or more unmet needs at the time the exposure was ascertained. And the proportion of unmet needs varied depending on which category you looked at, anywhere from 0 to 15% for durable medical equipment to about 0 to 50% amongst home health services. Now, another important information that can be gleaned from this table is that the median number of unmet needs was 0, with an interquartile range of 0 to 1. So any comparisons that we are going to be talking about are essentially between comparisons between patients who had no unmet needs and those who had unmet needs. So coming to our 90-day outcomes, among the cohort of 195 patients, about 29% of patients were either dead or readmitted within 3 months. And numbers were predominantly driven by readmission rather than death. And another key part of this key observation, I would say, is the time to readmission. And if you look at that, it's about 12 days for patients who were readmitted, which is extremely, extremely early. Coming to the primary outcome. So looking at the primary outcome, we did not find a statistically significant difference between patients who had higher unmet needs, in this case, any unmet needs, versus those who did not. And looking into the constituents of the primary outcome, we did not find any statistically significant relationship. Then we looked to explore what are the drivers of these unmet discharge needs. And we did a random forest model, and the best performing random forest model had an out-of-bag error rate of around 33%. And the 4 top predictors were hospital length of stay, Apache 2 scores, multidimensional perceived social support, and age. And of these two, only actually, like none of these seem to be quite modifiable. Now, once these were placed into Poisson regression, only 2 variables came out to be significant, namely the hospital length of stay and age. So, putting all of these into perspective, what we found was that most respiratory failure survivors had non-medication needs identified at discharge. And the proportion of needs that went unmet varied from 0 to 15 to 0 to 50%. And greater than about 2/5 of acute respiratory failure survivors had 1 or more needs unmet. However, we were unable to find any statistically significant relationship between unmet needs and the composite outcome. So why are our results important? First, they show the magnitude of mismatch that exists and specifically identifies areas that are vulnerable. Now, to put a few things into perspective, about 31.3% of patients prescribed non-invasive ventilation did not receive them at the time that the exposure was ascertained. And about 50% of physical, occupational, and speech-language pathology appointments remain unfulfilled as well. And readmissions occurred early. Why is this important? Because our traditional follow-up systems, even where we have robust ICU recovery clinics, do not start until 4 weeks to 3 months. However, the readmissions, as we see here, happened at around a median of 12 days. We were, however, unable to ascertain if there was a clear impact of post-recovery ICU clinics in our cohort because only about 16% were enrolled in such programs. And it seems that older patients with long hospital length of stay appear to be the most vulnerable. So what are our strengths? So ours was a multi-center study conducted across the breadth of the United States. We had an exceptionally high cohort retention rate of about 95 to 96%. And we had developed this discharge needs tool with multidisciplinary input. What are the limitations? The biggest limitation of our study is the early readmission rate. So the median time to readmission was about 12 days, which may have led to inaccurate or misclassification of exposure in a certain subset of patients. And although we quantified the discharge needs as either met or unmet, we were not designed to assess the quality of services that were provided. Generalizability of our study can also be called into question because this was conducted at tertiary level academic medical centers, and these might not apply to smaller centers with less robust follow-up infrastructure. And although we were able to rule out a large effect due to our small sample size, we can certainly not rule out a more modest effect that may exist. And as with any observational studies, we cannot rule out residual confounding. So in conclusion, our study demonstrated that unmet non-medication needs remain extremely common among the survivors of acute respiratory failure, and these point out to areas which might need more careful introspection as we plan and optimize recovery for our patients. So if there was one take-home message, that is the stark mismatch that exists even till this date, even at tertiary level medical centers. With that, I conclude. Thank you very much. So, sorry.
Dr. Bose, thanks for an outstanding presentation. My privilege next to introduce Dr. Robert Tasker, my colleague who's editor-in-chief of Pediatric Critical Care Medicine, to introduce the next article. Robert?
Good afternoon, everyone, and thank you, Tim. I'm pleased to introduce our next speaker, Dr. Michaela White-Nesfield, who will be presenting a paper on pediatric critical care associated parental traumatic stress beyond the first year. Dr. White-Nesfield is an assistant professor in the Pediatric Critical Care Division at Children's National Hospital. The primary aim and focus of this research is the pediatric intensive care associated child and family post-traumatic stress disorder, with the ultimate goal to determine the role of parent and child traumatic stress management in improving long-term outcomes of children in the PICU. This article is being simultaneously released in Pediatric Critical Care Medicine.
Thank you so much to Dr. Tasker and the Board of Pediatric Critical Care and SCCM for the ability to present this article today. So, as Dr. Tasker said, I would be presenting on PICU-associated parental post-traumatic stress beyond the first year. And this is my team, without whom this work would not be possible. So this all started with the question, where do we go from here? If we look at PICS or PICS-P, we see that there are long-term effects after a child is admitted to the ICU that we're trying to discern how that relates to their reintroduction into society. And our thought as a team was, if a parent is affected, how does that affect a child's reintroduction after critical care? So we started with the question that has been answered by many colleagues before, what is medical traumatic stress? And here we look at DSM-5 to really give us the thought on acute and post-traumatic stress, where we have a traumatic incident. In this case, we look at the PICU admission as our traumatic incident, and then we look at symptoms associated with post-traumatic stress disorder as a whole. And we say for acute traumatic stress, we're looking at 2 to 4 weeks after a child's been admitted to the ICU. And then for post-traumatic stress, we have the tincture of time to say greater than 4 weeks after admission to the ICU. And so why study traumatic stress? A lot of times we look at a child in the ICU and we look at outcomes related to that child, but parental traumatic stress in particular, when we look at acute stress, we're looking at 1 out of 3 parents meeting DSM criteria. And when we're looking at acute stress symptoms that don't meet criteria for disorder, up to 70 to 80%. It's quite a large number. For post-traumatic stress, we're looking at 1 out of 5 parents. And then for post-traumatic stress symptom, a very broad range from the multiple articles that have been published in this area of 20 to 80%. So then not only can we say, okay, our parents may be affected by their child being admitted to the ICU, but how does that relate to the family and to the child themselves? And here we see increased child psychiatric behavioral disorders and parent and spouse psychiatric issues, something called multi-generational or intergenerational trauma, where you can have either psychological or sometimes even physical change in how family members respond to trauma, increased parental substance abuse and deficits of head of household abilities, and increased financial stress for the family. And this data is not only seen in the pediatric ICU population, but in post-traumatic stress in parents throughout many different niches. So then we said, well, what do we not know? We've had multiple articles that have been presented that say, yes, we have post-traumatic parental stress from the ICU, but really those articles have focused within the 12-month period, with one article going out to 18 months. And so our question was, what really happens to these parents outside of that range? And so we wanted to evaluate the percentage of parents meeting PTSD diagnosis at about 2 years post-discharge. And then what are the risk factors for these particular parents, and how do they compare to risk factors for acute traumatic stress and for short-term post-traumatic stress, which we defined in our study as less than 18 months. And then the effects of post-traumatic stress and PTSD symptoms on how a child and family does from a psychosocial and economic sense. This is a 2-center prospective cohort study, and we enrolled from July of 2016 and finished our follow-up in January of 2020. So our inclusion criteria were parents of children 0 to 17 years who had been admitted to the PICU unexpectedly and admitted for greater than 48 hours. And then for our exclusion criteria, on the basis from our psychiatric and psychology colleagues, we decided to exclude parents who had recently, within the last 2 years, been admitted for a psychiatric disorder, or parents who were suspected of their child dying in the ICU imminently, or who died during the study period. And the reason for this was we felt that it would be difficult to differentiate grief and other psychiatric disorders from post-traumatic stress disorder related to the ICU, and also felt that if anything, we would underestimate how many parents were meeting criteria versus overestimate because they had already been evidence that mental health disorders and grief potentially can lead to increased levels of PTSD. We also decided to exclude parents of children who were suspected or confirmed of physical or sexual child abuse during that admission, and non-English speaking parents, simply because our study tools were not validated in other languages. So talking about study tools used, we decided to use the Post-Traumatic Symptoms Scale interview version for DSM-V5 because it allowed us to get a deeper sense of which symptoms were bothering our parents, because it is an interview scale. And we did use the cutoff point of greater than or equal to 23 as our cutoff for a probable PTSD diagnosis that has been validated by the developers. For acute stress disorder, we used the Acute Stress Disorder Scale for DSM-V5. For prior psychiatric illnesses, which we tested when a parent came into the ICU, we used the PHQ. And then we had internal questionnaires which looked at demographics, previous history of both parent and child from a psychologic perspective, medical perspective, and socioeconomic perspective. So when looking at the assessment timeline, we approach parents during the admission within 3 to 14 days of their PICU admission. And this is where we establish the PHQ and additional questionnaires looking at their demographics and socioeconomic standing. And then we looked at a child's functional status. We again repeated at discharge functional status, and this was to evaluate whether there was a substantial change in a child's functioning while they were in the ICU. And we also did the Acute Stress Disorder Scale to evaluate the acute stress that was experienced by the PICU admission as a whole. At 3 to 9 months, we assessed parents with the PSSI-5 and also additional questionnaires to evaluate things that had changed from the discharge date, whether it be medical, socioeconomic standing, and additional questions about the child's medical health as well. And then we repeated this at 18 to 30 months. When we look at the enrollment demographics, we had a total of 265 parents, and of a female gender, we had 58%, which we were lucky to enroll 42% of fathers or male genders, because this is quite large for this niche of study. And then we had a pretty even split of 55%, slightly more enrollees at Marie Ferraris Children's Hospital. Interestingly to us that I want to highlight is that we found with the PHQ that 24% of our parents screened for active psychiatric disorder at time of admission. And also that almost 50% of our parents had experienced either themselves or another close family member outside of the child who had been admitted to an ICU in the past. When looking at the children, we had 188 children that were enrolled, and history of chronic disease was quite prevalent, so about 50%. And then also history of previous NICU or PICU admission was 57%. Most of our children were expected to survive to discharge with a median PRISM score of 3. And then also wanted to highlight, outside of length of stay, that was about a week, that we had about a 30% significant change in functional status for this cohort of children from the start of their ICU admission to the end. So in looking at our retention, we were able to retain 73% for our 3 to 9 month cohort and 66% for our 18 to 30 month cohort. And both of these timeframes were chosen, one, to kind of match the existing data that is usually around 3 to 9 months post-discharge. And we wanted to look at the period at around 2 years post-discharge. So that explains that kind of wide timeframe for the final assessment. So in the first primary report of our results, at 3 to 9 months, we had about 15% of our parents meeting criteria for probable PTSD. And at 18 to 30 months, we had about 13%, which was less of a drop than we expected, to be honest. And then looking at post-traumatic stress symptoms, we had 75 subjects at 3 to 9 months, or 38%, and about 34% at 18 to 30 months post-discharge. So our big question was whether or not this was trajectory of post-traumatic stress disorder, or were we evaluating parents who had newly become or newly met diagnosis for PTSD at 18 to 30 months. So about 60% of our participants completed both T2 and T3 assessments. And out of those 160 parents, 11 met criteria for PTSD at both time points. We have another 11 or 7% meeting PTSD criteria only at T2, or 3 to 9 months. And at 18 to 30 months, we had new onset parents who were now qualifying for PTSD criteria who had not done so previously. With looking at the 22 parents that met PTSD criteria at T2, you had 11 that continued, as we talked about previously, to have PTSD at 18 to 30 months. And of the 11 who had resolution of their PTSD, 64% of them still met criteria for significant post-traumatic stress symptoms at 18 to 30 months. And of the 19 parents that met criteria for PTSD at 18 to 30 months, you had 8 who were newly developed at 18 to 30 months, as we discussed previously. And of these 8, 63% had met criteria for significant post-traumatic stress symptoms at T2. So in looking at the results where we examined the risk factors for post-traumatic stress disorder, we looked at the parents that met criteria at 3 to 9 months and found that parental concerns of injury during the admission and meeting acute stress disorder at discharge were highly associated with meeting criteria for post-traumatic stress disorder. And then, interestingly, the more knowledgeable a parent was about their child's illness was also significantly associated with parental post-traumatic stress. And then how affected a child was, so the higher their POPC score in terms of how they were functioning, was also significant for post-traumatic stress. In looking at our primary outcome for risk factors, which is PTSD at 18 to 30 months, again, acute stress disorder at discharge was highly significant. And we have parental concerns not so much about what happened in the ICU, but now an overall concern that their child is now more susceptible to death after discharge being significant as well. You had a history of self or family member admitted to the ICU, which we were interesting to find that this showed up in our multivariable analysis at 18 to 30 months, because as you note, it was not part of the analysis at 3 to 9 months. And then our most interesting outcome, at least from our perspective, was there was a decrease in family income that was measurable and significant between T2 and T3, so 3 to 9 months to 18 to 30 months. So we thought to ourselves, looking at the overall trends, for short-term post-traumatic stress disorder, you had pre-admission factors being the mainly highly associated with post-traumatic stress disorder in our parents, and admission factors such as parental concerns. Whereas for long-term post-traumatic stress, we had a lot of post-admission factors. And it kind of begged the question, can we put all of these parents together, or do we need to have multiple time points in which we are evaluating parents and possibly extending the olive branch of treatment or mitigation factors? So then we thought to ourselves, and I would like to preface that this data has not been confirmed by other studies. And so this is our group just looking at our data and thinking through strategies. Is if you look at admission, discharge, and post-discharge, are there time points for screening and interventions? And from previous studies and ours as well, we looked at social determinants of healthcare and mental health status as an intervention time point if we screen for this at admission, and then at discharge, acute stress disorder being the main one, and post-discharge, whether it be in ICU clinics or in our pediatric clinics, whether screening for post-traumatic stress disorder and offering intervention would be helpful. And next steps for us would be using our data to try and create a prediction model. You know, we recently had publications looking at post-traumatic assessment scales that has been used for adults. And then the evaluation of qualitative themes, which we also collected data for in this study. And overall would be planning and testing interventions on targeted patient populations and increasing feasibility of those interventions. Thank you so much for your attention.
Thank you, Dr. White-Nesfield, for an outstanding presentation. The last paper will be introduced by my colleague, Dr. Christopher Seymour of JAMA.
Thank you, everyone, and thank you, Tim. On behalf of JAMA, as well as Professor Kirsten Bibbins-Domingo, who's joined us today, our editor-in-chief, I'm pleased to introduce Andreas Schibler, who has over 30 years of academic work focused on improving the clinical outcomes of children and the respiratory support they receive. His research highlights include the Paris studies, which have investigated improved respiratory support for children who require oxygen therapy. Dr. Schibler today will present effect of early nasal high-flow oxygen for children with acute hypoxemic respiratory failure, the Paris 2 randomized clinical trial, which was just recently released in JAMA. Thank you.
Thank you, Chris, and thanks the conference organizer for inviting us to present the early high flow in children with acute hypoxemic respiratory failure. This study is a study that comes out of a large body of work by the same group, particularly the PREDICT group in Australia and New Zealand. These are my disclosures, nothing that interferes with the presentation of the results. So we studied in the past nasal high flow and bronchiolitis, and we're still trying to find its way, how to use it. We've got some evidence, particularly during the COVID-19 pandemic, and high flow has been sort of a standard therapy in NICU and PICU. But we don't have any good evidence in the older children than 1 year of age. And since children are not little adults, we need to generate our own evidence in the pediatric field. So we first performed quite a large randomized controlled pilot study to inform our larger randomized controlled trial. We performed this pilot data in 2 tertiary children's hospitals in Australia. They were aged between 0 and 16, and they all needed oxygen therapy because they were hypoxemic. As you can see that the majority of the children were in the age bracket 1 to 5, so 80% of these patients presenting to the emergency department are in this age bracket. And most of these children, roughly 70–75%, present with a wheeze, so obstructive airway disease with increased work of breathing. And in the pilot trial, what we could show is that treatment failure on their allocated oxygen therapy was slightly higher in the standard oxygen group, and we had, interestingly, a little bit more ICU admission in the high flow group compared to the standard oxygen in the pilot trial. And you can see only one child got intubated out of more than 500 patients. So that led us to the question, what is a good candidate for a bigger trial as the primary outcome? Escalation of care is probably not necessarily the best outcome because parents do not mind to be admitted with their child to ICU, so that kicks out as well ICU admissions. Intubation and invasive ventilation would be very interesting, but a very low incidence rate of intubations in the pilot. So we dealt then with length of stay in hospital as the primary outcome. The target population was then children between 1 and 5, because that's the majority of these patients presenting either with a wheeze or absent wheeze. They needed to be hypoxemic, and of course they needed to be admitted to hospital. And the trial started with oxygen therapy, obviously in the emergency department, and continued in the general pediatric ward. This is the flow diagram. You can see we had a large screen population, and we enrolled then in the end more than 1,500 patients into either nasal high flow or standard oxygen therapy. Now, if you can go down in the flow diagram, you will see that from the nasal high flow group, a lot of children turned back to standard oxygen. More than 300 patients were flipped back to standard oxygen. I get back to this figure later on because it's a very important outcome. The trial was performed according to standards with a 1-to-1 random allocation to standard oxygen or nasal high flow in 14 metropolitan and tertiary hospitals in Australia and New Zealand. And we could complete the trial just before the pandemic hit us, because that would have jeopardized the study flow and as well the use of nasal high flow. And as I said, primary outcome was length of stay. I won't bore you too much with the baseline characteristics. They are very similar in both arms and very well distributed. That just leads to a good study performance. Now, the primary outcome, nothing was significant in comparison to standard and nasal high flow. I highlight here the length of, go back. So length of stay in nasal high flow was 1.77 days, in standard oxygen 1.50 days, and that makes a 6.5-hour difference in the length of stay. So we wanted to demonstrate that nasal high flow reduces the length of stay in hospital, which we couldn't demonstrate. The rest as well of the primary outcome allocated or investigated in the different groups, like absent wheeze or present wheeze. There's no difference at all between the two groups, or in other words, nasal high flow wasn't superior to standard oxygen therapy. Now, if you get to the secondary outcome, I just highlight a few of them that are important to understand and may change your practice in future. First of all, if you look at the ICU admissions, there was a significant greater proportion of patients in the nasal high flow arm that were admitted to intensive care, which was to us again very surprising. And if you look at do they need more invasive ventilation or non-invasive ventilation, there's no difference in the two arms. And if you look at 4 patients out of more than 1,500 patients needed invasive ventilation. So sort of the study is performing well. We couldn't demonstrate a difference in the two groups, but however, we can say that we have a very, very low intubation rate in this population. Now, another aspect is that some of these hospitals didn't have an on-site ICU. So for a child that needed ICU treatment, these children were transferred in an ambulance, rotary, or fixed wing to the next tertiary children's hospital. So if we look at the transfer rates to a PICU, you can see that we have only 2.3% in the nasal high flow and 2.2% in the standard oxygen arm who needed a transfer. So much lower than the overall population. And the overall population was driven by hospitals who have direct access to intensive care. And you can see as well in this subgroup of hospitals without on-site ICU, the length of stay was shorter in the nasal high flow arm compared to the standard oxygen arm. I'm not giving any p-value because that wasn't pre-planned in the analysis. Now, a second look at these PICU admissions. You can see first the total cohort, 12.5% in the high flow arm and 6.9% in the standard oxygen arm. In the hospitals who have an on-site ICU, this number climbs up to 13.8% compared to 7.6% in the standard oxygen arm, whereas hospitals who have not a direct access to an ICU have a much lower, so almost fourfold lower ICU admission compared to the tertiary children's hospitals. Now, I highlighted in the consort statement, flow diagram, that a lot of children got switched back from nasal high flow to standard oxygen. And you can see that here very clearly, that tolerance was a problem. So a lot of these children didn't tolerate or didn't like the nasal high flow, which is very different to what we observed in the previous trials. Now, the reason why and how they got changed back to nasal high flow, you can see when a change in oxygen therapy occurred. In the standard oxygen arm, it was because they got sicker. They had an increased work of breathing, where in the nasal high flow arm, the kids were actually better and didn't tolerate anymore the nasal high flow. So they rip it off because they don't like it. Now, how does this trial compared to our previous trial in bronchiolitis? So the previous trial was Paris 1, was performed in infants less than 1 year of age with bronchiolitis, and they were as well hypoxemic. We performed this trial as well in 17 metropolitan and tertiary hospitals. However, the outcome was different. We looked at escalation of care. But if we look at the secondary outcomes in the Paris 1 trial compared to Paris 2, we can see as well that the duration, the length of stay was slightly longer in the high flow arm with 3.12 days compared to 2.94 days. And the difference is 4.3 hours. So again, when a patient is placed on nasal high flow, it seems that they stay just slightly longer, but it can be relevant if you look at patient flow within a hospital. And here again, the ICU admissions, we have more ICU admission in the Paris 1 trial compared, if we compare nasal high flow to standard oxygen. And if you compare here again, the transfer to ICU from another hospital, in both arms, the ICU admission proportion is exactly the same. So, which means that obviously these peripheral hospitals outperform the tertiary hospitals because there's no difference in severity of the disease. So in conclusion, nasal high flow didn't reduce the length of stay, and that was our primary question. And we couldn't identify a subgroup that particularly benefits from the treatment with early high flow. A greater proportion needed ICU admission in the nasal high flow group, but as I showed, this was more driven by the fact having an on-site ICU than not having an on-site. So that means we need to really think what we're doing within the hospital and how we change our practice using nasal high flow. Nasal high flow doesn't mean the patient is automatically sicker and then we refer this patient to ICU, because our metropolitan and regional hospitals have very clearly shown they keep these patients in their hospital without the transfer. However, tolerance of nasal high flow is still a problem and is probably not that well tolerated, and needs to be reconsidered how we're going to use it. But we can certainly conclude with almost no adverse events in our study that nasal high flow can be safely used outside ICUs and as well in hospital without any on-site ICU service. So thank you very much.